DIC simplified. So DIC is disseminated intravascular coagulation. So understanding what does it means. Introduction. DIC is a pathophysiological process. So the physiology here that is deranged is the hemostatic process. So there is an excessive activation of hemostatic process causing DIC and causes DIC. So initially there is an adequate compensation for this hemostatic process activation. So only seen in lab tests. So it can only be detected in lab test. If there is a severe acute DIC, which the normal DIC can progress, it will manifest as a significant bleeding. And secondary fibrinolysis will again cause more bleeding, which will be associated with end organ failures. So pathophysiology is when there is consumption of coagulation factors and platelets. So this will go along with fibrin will cause microvascular obstructions and end organ damage. Significant consumption after that there will be manifestation as a bleeding. So the question comes is, why is there an inappropriate activation of hemostatic system? So when we answer the question of why, we will get the reasons or the causes of DIC. So the first thing is because of the release of thromboplastin in circulation. The causes for release in thromboplastin in circulation is extensive trauma, surgery, malignancy, or acute intravascular hemolysis. Then endothelial injury will cause platelet activation, which in turn will cause hemostatic system activation. That is caused by endotoxin, mostly gram-negative bacteria, viral infection, extensive burns, prolonged hypotension, hypoxia, acidosis. The third reason for the inappropriate activation of hemostatic pathway is platelet activation. Platelet activation is caused by septicemia or antigen antibody complex. So this sums up the causes of DIC. Then there will be some clinical features, how well this DIC present. So the presentation is variable. So basically there is two things. There is an ongoing thrombosis which can present as a thrombotic state. Then if it is acute and the coagulation factors cannot be compensated, then it will cause hemorrhage, which is the major problem, and that will manifest as bleeding at surgical site, wound, venipuncture, or generalized bruising. And there could be a mixed presentation of thrombosis and hemorrhage. So the lab findings depends upon the basic physiology. Fibrinogen will convert it to fibrin, and then this fibrin will get lysed. So the test which detects the decrease in fibrinogen or hyperfibrinogenemia can be detected. Since the fibrin is getting lysed, the lysis products, which is measured by D dimer, can be seen. So there will be an elevation of D dimer, and since the fibrin will take platelet and RBCs in forming a clot. So when the RBC will get lysed, and there will be cell fragmentation. So this lysis of RBC and cell hemolysis that can be seen on a peripheral slide is usually present in a case of a chronic DIC, whereas when the platelet will be consumed, they will present as thrombocytopenia, and along with that there will be increase in APTT, PTT, PT and TCT. So how will you diagnose? So all these tests will indicate towards DIC. A more specialized test that are now can be used is fibrinopeptide A, and there is a decrease in, when you measure the values of antithrombin, there will be a decrease in the antithrombin levels. So how is the diagnosis made of DIC? The diagnosis is basically clinical plus lab findings, in which the lab is very important. So To clear things out, because there are so many things going on, there is this International Society of Thrombosis and Hemostasis. So they made an algorithm for the diagnosis of overt DIC. Okay, this is for overt DIC acute, not for chronic DIC. So they took into account platelet, elevated fibrin degeneration products, and prolonged PT and fibrinogen. So uh, 0, 1 and 2 points were given. If the score is more than 5, then it is an indicative of overt DIC. Whereas in the case of chronic DIC, which is mainly seen, we already know, in malignancies, so there is compensation of the thrombosis that is going on, hemostatic process that is going on. So there will be almost normal to near normal hemostasis test like PT, PTT will be almost normal, but there will be an elevation of D dimer and red cell fragmentations can be seen. So what is the management or the therapy that you have to give? So the in so diagnosing DIC is not a very big difficult task, but the management is to be very judicious. For treating the limiting cause, treating the initiating cause, we know the causes of DIC. So if they can be treated, then that is the first goal. And with that, we have to give supportive measures like maintaining perfusion, BP, and ventilation, and managing the shock component of DIC due to hemorrhage. And when we are doing all this, then the question will come about transfusion. So the transfusion is, if we transfuse early, it would be like feeding the fire, like we are giving substrate for microthrombi formation. Hence, transfusion should be limited only to patients who are bleeding or at a high risk of bleeding, or are to undergo some procedure, some major surgical procedure. So the basic aims are platelet should be more than 20 to 30 into 10 to the power 9 per liter. Fibrinogen should be 1 to 1.5 gram per liter, and platelet and prothrombin time 1.5s of normal. So when this is regarding bleeding. So when there is thrombosis going on, so this is generally seen in chronic DIC when thrombotic complications have occurred rather than bleeding. So we give unfractionated heparin initially, and then we can switch over to other anticoagulants. Antithrombin therapy has been tested, but they have a varying result on patient mortality. So this is basic about DIC. Thank you.